Yes. Okay. 1, 2, 3.
Okay. Hi, everybody. Good morning for some. Good evening for others. Thanks so much for coming here today. I am Professor Miguel Souza, and together with Professor Marcelo Souza, my colleague from the medical course in the university, in the Federal University of Ceará, will present great authorities talking about GERD and GI motility. During the first hour, Professor Uday Ghoshal from India and Professor Daniel Sifrim from London will show their presentations. During the second hour, Professor Ricardo Oliveira and Dr. Gabriela Bueno from Ribeirão Preto, Brazil, Dr. Carla Granja from São Paulo, Brazil, and myself will present short case reports. The audience, you, is invited to post comments and questions at any time. I would like also to say thanks to Achalasia and also to Dr. Ricardo Viabig for supporting us. Well, let's start. I invite Professor Ghoshal to start the presentation. Professor Ghoshal is from the Department of Gastroenterology in the SGPGI, Lucknow, India. He's president of the Indian Motility and Functional Disease Association and contributes as an editor to important gastrointestinal journals. Thank you so much, Professor Ghoshal. Come in.
Good morning. For me, it is good evening. It is a pleasure for me to talk in this important session on functional esophageal disorder, and also Professor Daniel Sifrim will talk about gastroesophageal reflux disease. So, can you see my slide?
Yes, Professor.
So I'll be talking about high resolution manometry and its clinical utility in diagnosis of esophageal motility disorder. Truly speaking, in this short time, I'll give you the concept, and subsequently, through case-based presentation, we'll learn more. Now, obviously, we cannot share everything in half an hour. So if somebody wants to know more, these are the two books on GI motility that we edited, along with Satish Rao and Professor Lee from Malaysia. And I think you are welcome to go through these books. When we are talking about esophageal testing, you have to realize that one thing is we test the structure of the esophagus by radiology, conventional endoscopy, advanced endoscopic technique, esophageal capsule endoscopy, endoscopic ultrasound, and histology. But what happens is this investigation primarily tests the structure of the esophagus, which is altered particularly in organic diseases such as esophageal stricture, esophageal cancer, and so on. But a lot of patients come with symptoms. Those symptoms cannot be sort of explored by the investigation for structure, and there you need esophageal functional testing. And when we talk about esophageal function testing, we are referring to motility testing, which include esophageal manometry, which earlier used to be conventional manometry, but now we talk about high resolution manometry. Also, many machines have impedance technology added to the manometry system. High frequency endoluminal ultrasound primarily tests the longitudinal muscle function of esophagus. On the other hand, esophageal manometry primarily tests the circular muscle function of esophagus. Endoflip is a popular technology now, particularly to assess lower esophageal sphincter. When we talk about reflux testing, we refer to catheter-based pH metry, which in the past used to be single channel, but nowadays we hardly ever do single channel. It is a multiple channel pH metry. But more than that, for diagnosis of reflux today, we talk about impedance-pH monitoring. Bravo capsule monitoring was promoted once upon a time, but I don't think this is a very good technology currently because it is expensive and it does not talk about impedance at all. Mucosal impedance is an emerging technology. When we are talking about transit, we refer primarily to radionuclide esophageal emptying, though impedance monitoring itself during manometry can give an idea about transit. Now, what are the indication of esophageal manometry? Motor dysphagia. So what is motor dysphagia? Dysphagia without any mechanical obstruction is motor dysphagia. Non-cardiac chest pain, gastroesophageal reflux disease, in which case we don't need manometry only to assess the esophagus, but we also need to assess, or we have to localize the LES so that we can place the pH probe in the right place, which Professor Daniel Sifrim is going to talk about in a greater detail. Systemic diseases with esophageal involvement, for example, progressive systemic sclerosis with dysphagia. So there you talk about esophageal manometry. And in patient with dysphagia, when we suspect EUS dysfunction, we may do a body manometry just to tell that the body function of the esophagus is normal. Now, motor dysphagia and mechanical dysphagia differentiation start from history taking. We should not base everything on investigation because investigations are often invasive and they are expensive. Therefore, one should take a thorough history. And in fact, in clinical medicine of current day, this history taking is taking a back seat, but I would say that is not a right approach. So motor dysphagia is typically intermittent. It is dysphagia to solid or liquid together. Many books will describe liquid dysphagia start fast. More with extreme temperature of the food, patient learn that if they raise their arm, straighten their back, the dysphagia becomes less. This is because they try to press the esophagus between the anterior chest wall and the posteriorly the vertebral column. Therefore, they open the LES by increasing the intraesophageal pressure. Motor dysphagia typically is a long duration dysphagia. Episodic chest pain is highly suggestive of motor dysphagia. Regurgitation again is highly suggestive, and it basically means this is a dilated esophagus with retention of the food. And in case of motor dysphagia, weight loss is much less than the mechanical dysphagia. So once we know that our patient is suffering from esophageal dysphagia and not transfer dysphagia. Transfer dysphagia is typically associated with neurological illness, where patient will have nasal intonation of the voice, nasal regurgitation of the food, and typically they will say inability to push the food back into the pharynx. Now in those patients, obviously we are talking about transfer dysphagia. But when somebody does not have transfer dysphagia, it is esophageal dysphagia. The first job of the clinician is to differentiate whether we are dealing with a patient of motor or mechanical dysphagia. And if this patient is suffering from motor dysphagia, we investigate the patient. In the past, barium swallow was a popular investigation, but nowadays we know that barium swallow is a very crude test, but sometimes in patients with motor dysphagia, it can give idea such as megaesophagus. So what is megaesophagus? It is an esophagus which is dilated 7 centimeter or more, and these patients often don't do well with esophageal balloon dilatation or pneumatic dilation. Now, there we replace the barium esophagogram with timed barium esophagogram because timed barium esophagogram gives a better assessment of esophageal emptying. In this, we give 100 ml barium 45% weight by volume. We take X-ray at 1, 2, and 5 minutes. We look at the height of the barium at 1, 2, and 5 minutes. Sorry for the mistake here. We also see volume at 5 minutes, and this represents esophageal emptying. Therefore, it is related to lower esophageal sphincter pressure, which is increased in some patients with motor dysphagia, such as achalasia cardia, but more often they have a non-relaxing LES, and therefore their emptying is impaired. But let us talk about esophageal manometry, which is the gold standard investigation for patient with motor dysphagia. Now, earlier we used to do conventional manometry, so I'll touch on this little bit so that we understand what is new in high resolution manometry. Now, this manometry could be water perfusion manometry or solid state manometry with impedance. We have both the system in our laboratory. Only problem is in many countries, typically the developing countries, where the cost of care is very important, I find that solid state manometry is quite expensive. Now, the catheter could be water perfusion. Here we have the catheter which contain multiple capillary tubes. Now, these multiple capillary tubes open at different locations along the length of the catheter. Now, through this tube, water is perfused at a constant rate, and whenever there is a lumen-occlusive contraction in the esophagus because of circular muscle activity, actually there is impedance to the flow of water. And this impedance to the flow of water leads to increase in the pressure, which through the transducer is actually recorded as a digital signal in the computer screen. On the other hand, in solid state catheter, typically you have two metal rings, and these rings actually, whenever these metal rings come close to each other because of circular muscle contraction, this leads to variation in temperature locally, which is actually recorded by the system. Obviously, I told you that manometry typically assesses the circular. I'll show you later with the current high resolution Klaus plot, actually you get a good idea of the longitudinal muscle activity as well. Now let us say this is the esophagus, and you can see those round yellow circles represent the manometry port. Now when a fellow swallows, what happens is that the bolus goes through the esophagus. Obviously, esophagus contract and relax in different locations. So the location above, esophagus is contracting, but at the same time, location below, it is relaxing, and that leads to propulsive activity, which propels the bolus into the stomach. And this propulsive activity is recorded by the manometry system. This is the port at lower esophageal sphincter, and as you can see here, when the pharyngeal activity starts, simultaneously as a reflex activity, lower esophageal sphincter relaxes, and it remains relaxed till the bolus has crossed the lower esophageal sphincter and entered into the stomach. And obviously, after the bolus has crossed, there is a rebound increase in the pressure, then the LES pressure comes down to the baseline. Now, what is high resolution manometry? Now, if you have to understand what is high resolution manometry, it is good actually to understand what is conventional manometry. In the conventional manometry, the x-axis represents the time and the y-axis represents the amplitude of contraction. So y-axis represents the amplitude of contraction, x-axis represents the time. And when the swallowing occurs, the muscular activity increases the pressure, and this pressure is recorded like an upward and downward deflection. Also, you have to understand that most conventional manometry system had lesser number of port. For example, about 30 years ago or 25 years ago, when I was doing manometry in our laboratory, typically it used to be 6 or 8 port conventional manometry system, where 2 port used to be in the ileus, 1 port used to be in the stomach, and the remaining 4 or 5 port used to be in the esophageal body. So therefore, what happened is it had a limitation. What was the limitation? The limitation was here. So what happens is, let us look at this diagram. This is only maybe 6 or 8 port on the left side. Now, if there is a sweeping contraction like this, which squeezes the manometry catheter, but the squeezing occurs in the location between the port, this particular peristaltic activity will not be recorded. On the other hand, current high resolution system has large number of port, for example, typically 32, even we have 64 port manometry system. Therefore, there is no way that such contractions will be missed by this system. Second thing is, I told you the conventional manometry, x-axis represent the time, y-axis represent the amplitude of contraction. Now in the high resolution manometry system, x-axis represent the time, y-axis represent the esophageal length. So therefore, how do you represent the amplitude of contraction? This novel idea was brought in by this gentleman, Ricardo. So Ricardo, what he did is, to represent the amplitude of contraction, he gave color. So he coded color, and I have given an analogy to this color coding in the high resolution manometry system. If you look at the nature, sea is blue, and deeper you go, it is more deep blue. Then you go to the paddy field, it is beautifully green. If there is a setting sun in the sky, you can see yellow and red, and at the top, you can see the black color. So therefore, the manometry has similar color coding, very easy to remember. More blue means negative pressure, more black means high pressure, and there are varying shades of green, yellow, and red in between. So this is called Claus plot, where an esophageal length is represented in y-axis, time is represented in x-axis, and the color gives you actually the amplitude of contraction. Now this is an example where you can see this is upper esophageal sphincter, high pressure zone. This is lower esophageal sphincter, which is again a high pressure zone. Above this EUS, you can see negative pressure, which is pharyngeal pressure. Below the LES, you can see negative pressure, which is intragastric pressure. And between the LES and the EUS, you have negative intrathoracic pressure. In between, with each swallow, you can see the contraction of the esophagus, which are sloping, means these are peristaltic. Now, we all know peristalsis can be primary, can be secondary, can be tertiary. So what is a primary peristalsis? Primary peristalsis is a swallow-associated peristalsis. So therefore, all the primary peristalsis will have EUS relaxation, through which bolus has entered from the pharynx into the esophageal body and then passed through the ileus. What is secondary peristalsis? Secondary peristalsis is in absence of swallowing. So therefore, it will not show any EUS relaxation. Typically, nature has given this mechanism to clear the refluxate, so that off and on the reflux that we have of the content of the stomach into the esophagus actually is pushed back into the stomach, so that there is no damage to the esophageal mucosa. And tertiary peristalsis is something like atrial fibrillation. It is typically the flickering contraction, which does not have much physiological significance. So these are the 3 types of peristalsis. Also in high resolution manometry, there is a zone just below the upper part of the esophagus, where you will get a pressure activity which is quite broad. It is a broad or a longer pressure activity, but it is a low pressure zone. So what is the explanation for this broad low pressure activity in the upper part of the esophagus? This is related to the muscle composition in that area. The muscle composition is that you can see in this area a varying proportion of muscle are either are skeletal as well as smooth. In the rest of the esophagus, you have only smooth muscle. But in this location, maybe 50% are skeletal muscle, 50% are smooth muscle. And we all know skeletal muscle is in response to a stimulus contracts very fast. But again, it becomes, or its contraction also disappear very fast. So it has a typically upward spike very quickly and then downward or downstroke also quickly. On the other hand, smooth muscle has plateau type contraction, but its contraction duration is quite long. So when 50% of the muscle are skeletal, in response to a swallow, they will contract very quickly, but the remaining smooth muscle will join the skeletal muscle later and will this contraction of the 50% smooth muscle will last longer. So therefore, all the muscles in this region are not working simultaneously. That's why it is broad. And because they are not working simultaneously, it is low in amplitude. Now let us look at the mechanism of swallowing. This is the esophagus. Now the moment a bolus enters into the esophagus, there is an increase in the pressure in the esophageal lumen. And this is called intrabolus pressure. Now you can see here, the moment upper esophageal sphincter muscle has opened, the color of this blue zone has become lighter. So lighter blue means higher pressure. And this lighter blue represents intrabolus pressure. The moment bolus enters, there is an intrabolus pressure. Now subsequently, what happens is, there is a contraction above this bolus, and this is the esophageal contractile front. So you can see here, this is the esophageal contraction or esophageal contractile front. Now simultaneously, the ileus relaxes. Now when the ileus relaxes, still there will be some pressure. Earlier we used to call it as a nadir pressure, but now the terminology is changed. And this terminology is integrated relaxation pressure, which I'll explain. So what is integrated relaxation pressure? This is a pressure, this is the minimum average pressure in the ileus region, over a 4-second window, which need not be consecutive. So this is minimum average pressure in the ileus region over a 4-second window, which need not be consecutive. That is called integrated relaxation pressure. Now what happens is, if the integrated relaxation pressure is low and there is a good gradient between the esophageal contractile front pressure above and integrated relaxation pressure below, the bolus moves. So this is the normal physiology. So when does dysphagia occur? When esophageal contractile front is very weak, and obviously the gradient between contractile front and IRP does not occur. Or when esophageal contraction is simultaneous, so that it doesn't propel the bolus, but it squeezes the bolus. Or when esophageogastric junction pressure or IRP is quite high. These are the three situations where dysphagia would occur. So the concept of integrated relaxation pressure, I already told you. So therefore, I skip this slide. What is the concept of DCI? DCI is distal contractile integral. So distal contractile integral, typically you calculate in a zone which is below the transition zone. That means it starts from here and till this deceleration point, which I will explain later. So what is DCI? DCI is amplitude of contraction into duration of contraction over an unit length of the esophagus. So it is amplitude of contraction into duration of contraction over an unit length of the esophagus. So what is CFV, or contractile front velocity? So if we know that when the contraction occurred here and when the pressure front rose here, now obviously there is a time gap between these two. So if we know how much time did it take for the contraction to come from this location to this location, and obviously from the catheter mark, we know how many centimeter is this. So we can calculate CFB as distance in centimeter divided by time in second. CFB is supposed to be less than 8 centimeter per second. That means it should be less, it should not be more. If CFB is too fast, that means it is moving too fast, more than 8 centimeter per second. That means there is lack of distal latency. So distal latency is less. And distal latency less means this is a simultaneous contraction or premature contraction. So currently in currently in Chicago 3 system, we have actually realized that CFB is not as important because distal latency gives us an idea whether the contraction is simultaneous or not. Now, I will not touch on impedance because impedance is a system which gives you flow of the bolus through the esophagus, and only some manometry system, particularly those which are solid state system, has impedance inbuilt into it. And currently Chicago system did not lay too much importance on impedance technology, but with time to come, maybe it will become important. Since I have given you a little brief, I want to tell you how important a well-done esophageal manometry is through a case story. This is a 19-year-old son of a doctor. He himself is a medical student. Now, this fellow started having dysphagia, regurgitation, and occasional heartburn, but no chest pain for 1 year. So he had dysphagia as a symptom, he had regurgitation, and he had occasional heartburn. Upper GI endoscopy done elsewhere was normal, and a high resolution manometry elsewhere diagnosed him having type 1 achalasia, and therefore a POEM or paroral endoscopic myotomy was planned. He also underwent a barium swallow, which showed somewhat dilated esophagus without any parrot beak. Now, see, since his father was a surgeon and he himself was a doctor, he thought before undertaking this POEM, which is quite irreversible sort of operation, he thought he should take a second opinion. Therefore, he came all the way from Calcutta to Lucknow for a second opinion. So he repeated the esophageal manometry. And what we found is, yes, there is some very low amplitude contraction, hardly any. It looked somewhat simultaneous, but not really. But what happened? It is relaxing alias. Is on impedance, we could find that his bolus was flowing beautifully in the stomach, as you can see here. You can even overlay on the pressure activity, and we found that there was not much bolus escape. So there was beautifully the saline was going into the stomach. We actually played this video for you, and you can see here each time there's a contraction activity actually. So bolus is going to, if you want me to play once more, let me play. You can see here the bolus is going to the stomach and then it is refluxing back. So we thought he may be having pH metry and it was grossly abnormal. So what was happening is he may be having a esophageal muscle disease, something like the the esophageal muscle, something like a scleroderma physiology. He has a low LES pressure, but it is relaxing very well because he has hardly any muscular activity. The manometry done earlier misinterpreted this movement of catheter as simultaneous contraction activity and led to an erroneous diagnosis of achalasia cardia, and he was going to undergo a poem. So you can understand a well-done manometry is very, very important. Now, also, when you see a patient of achalasia, be aware of pseudo-relaxation. What is pseudo-relaxation? When you do a high-resolution manometry, when the patient swallows, circular muscle actually squeezes the catheter, but longitudinal muscle shorten the esophagus. And because of this shortening of the esophagus, actually the LES gets pulled up. Now, in conventional manometry, sometime, and even some high resolution manometry also I have seen, some people places his window for IRP here, and you can think that this esophagus is relaxing or this LES is relaxing, and therefore it may not be achalasia. This is actually pseudo-relaxation. This is happening because the longitudinal muscle is pulling up the LES. So this is pseudo-relaxation. So this is Chicago classification, algorithm 3 or version 3. If you have done a manometry, look at integrated relaxation pressure first. If integrated relaxation pressure is greater than upper limit of normal, if it is greater than upper limit of normal, that is 15 millimeter of mercury per centimeter per second. 15 millimeter of mercury. So then what happens is you look at the peristalsis. If IRP is equal to or greater than upper limit of normal and 100% absent peristalsis or failed peristalsis, look at the esophageal body contractility. If there is no contractility, this is type 1 achalasia. If there is a pan-esophageal pressurization, this is type 2 achalasia. And if there is a segmental spasm with a distal latency less than 4.5 seconds, this is type 3 achalasia. On the other hand, if IRP is greater than or equal to upper limit of normal and the patient does not have simultaneous contraction as mentioned above, this means this is not type 1 or type 2 or type 3 achalasia. This is esophagogastric junction outflow obstruction. It may be an early stage of achalasia or it may be a mechanical obstruction. These two groups of disorder are together called disorders with EJG outflow obstruction. Now, if IRP is not like greater than upper limit of normal, that means IRP is normal, but the distal latency is short, like less than 4.5 seconds, and high DCI, so distal contractile integral is very high. I'll tell you later what is high. Then it can be DS. In DS, 20% of the contraction will be premature contraction, which means distal latency is less than 4.5 seconds. Jackhammer esophagus is greater than 20% had DCI of more than 8,000 millimeter of mercury per centimeter per second. Absent contractile activity, sorry for the mistake here. So absent contractile activity, I showed one patient where there was a muscle disease maybe in the esophagus. So therefore hardly there was any peristalsis. And these are major disorder of peristalsis which are not normally seen. Now, if IRP is normal and 50% or more have ineffective swallow, this is classified as ineffective esophageal motility, greater than 50% or equal to 50% ineffective swallow, or fragmented peristalsis. Fragmented peristalsis where more than or equal to 50% are fragmented. That means there is a large break in the peristalsis. These are minor disorder of peristalsis and impaired clearance. If IRP is normal and greater than 50% effective swallow. This is a normal manometry pattern. Now, these are like the sort of cutoffs. Contraction vigor failed means DCI less than 100 millimeter of mercury per second per centimeter. Weak means DCI between 100 millimeter of mercury per second per centimeter, but less than 450 millimeter of mercury per second per centimeter. Hypercontractile is DCI more than 8,000 millimeter of mercury per centimeter per second per centimeter. What is premature contraction? Distal latency is less than 4.5 seconds. What is fragmented peristalsis? When there is a large break, for example, more than 5 centimeter break in 20 millimeter of mercury isobaric contour with DCI more than 450 millimeter of mercury. Because if DCI is very low, it can be something like a very weak peristalsis or fatal peristalsis. And if none of the above are fulfilled, then this is intact peristalsis. Now, achalasia is further classified, as I told you, type 1 achalasia, where no esophageal pressurization exists. IRP is more than 15 millimeter of mercury, though in some studies, authors use more than 10 millimeter of mercury IRP as abnormal for type 1 achalasia. Why is it so? Because this esophagus does not have any contractile ability. Therefore, even if IRP is 10 or more than 10, 11, it cannot push the bolus. Type 2 achalasia is panesophageal pressurization like this with IRP more than 15 millimeter of mercury. Type 3 achalasia is segmental esophageal pressurization with IRP more than 15 millimeter of mercury. Obviously, my introspection is type 3 is the earliest disease, type 2 is little more advanced disease, and type 1 is the most advanced disease where esophageal muscle is totally gone because of denervation maybe. Therefore, truly speaking, type 1 should have been called type 3, but this is how terminology is. And type 2 achalasia responds best to the pneumatic dilation. The reason is very clear. Type 2 achalasia is the one where the muscle is still there. So therefore, esophageal body muscle is still there. So therefore, if we disrupt the non-relaxing LES, the muscle can actually squeeze the bolus down into the stomach. It is like a fellow who has, let us say, aortic stenosis. If you do an aortic valvotomy at the early stage of the disease, the fellow will be having better cardiac output than a patient of aortic stenosis having hugely dilated left ventricle with flaviventricular muscle. There, if you do aortic valvotomy, the response will not be as good. The analogy of this outcome is there only. So what is the value of esophageal motility and achalasia? It is gold standard for diagnosis. It differentiates DS from achalasia. Sometimes even people, when they did not develop florid picture on barium endoscopy or even in manometry, you can actually tell this looks like achalasia. Post-pneumatic dilation LES pressure measurement suggests adequate pneumatic dilation response. I will show this. Pain of a vigorous achalasia. Earlier, type 3 achalasia or even type 2 achalasia was called vigorous achalasia. And this patient has pain as a major symptom in addition to dysphagia. And if you do pneumatic dilation, pain may not respond, though dysphagia respond. DS may require a different treatment approach than achalasia. What is the value of esophageal manometry in GERD? I'll not touch on this because obviously Professor Sifrim is going to talk about this. LES pressure power studies found that if after pneumatic dilation, you reduce the LES pressure to below 22.5 millimeter of mercury, you have done a good job with a sensitivity and specificity to predict the outcome to the tune of 60 to 80%. But if you have reduced the LES pressure below 10 millimeter of mercury, you have done great job, and they often their response lasts longer, as shown here. There was also a good study from Michael Veggie's group, where actually they looked at time barium esophagogram and not manometry. So what they looked at, they in time barium esophagogram, if after pneumatic dilation you do a time barium esophagogram, there will be a group where time barium esophagogram has shown that there's a good yes disruption or good esophageal emptying. Another group had symptom relief, but the time barium esophagogram concordant group, and the during follow-up after the dialogue was as manometry was actual solution manometry, a lot of limitation, and we have to accept that this conclusion may not be very valid. Now let me show you a few examples and then stop end here. This is a normal manometry. This is a patient where there is a long transition zone or peristaltic break. This is a patient where there is a total peristaltic failure with low LES pressure, which may be associated with the progressive systemic sclerosis with esophageal involvement. But you can see similar pattern in patient of severe GERD or type 1 achalasia following dilatation and poem. And this is a patient who has a hypercontractile esophagus. You may call it jackhammer esophagus. Esophagogastric junction morphology. But because I'm already crossing my time, I will not elaborate on this in detail. This is actually based on whether the smooth muscle LES and the diaphragmatic pinch cock, they are together or they are separated. But I tell you, the clinical significance of this is yet to be sort of validated. Now, I was talking about Chicago 3 only. I did not refer to Chicago 4. Daniel, Sifrim, and I participated in Chicago 4 classification, and it is expected to be published in Neurogastroenterology and Motility soon, but I did not talk about it because still it is published. It is embargoed. Thank you so much. It was a pleasure sharing with you the esophageal manometry high resolution in investigation of esophageal motility disorder.
Thank you for the fantastic conference, Professor Ghoshal. I'm presenting myself. I am Professor Marcelo Souza from Fortaleza, and I'm the moderator of this section. I have a question from Hari from to Professor Ghoshal. Is type 3 achalasia a distinct pathophysiology entity as compared to type 2, type 1 achalasia, or all three are in the continuum with regard to the disease progression? What is your opinion, Professor Ghoshal?
Yeah, it is a very good question, I tell you. Actually, we believe that this is a continuum. And there are some data on this. People have shown that DS patient progress to different subtypes of achalasia. And in fact, we wrote a review article in this in World Journal of Gastroenterology. If somebody is interested, can go through. What happens is, what we believe is that initially there is a degeneration of nitrinergic system, and nitrinergic system is responsible for delay in the contraction in the lower esophagus, because normally nitrinergic neurons are in greater concentration in the lower esophagus than in the upper esophagus. This is based on studies in monkey esophagus from Raj Goel group. Now, this leads to normal peristalsis. Otherwise, actually, esophageal muscle is a syncytium, and it is supposed to contract together. So initially, nitrinergic degeneration lead to simultaneous contraction. But at that stage, cholinergic activity is still intact, and therefore the cholinergic activity leads to hypercontractility. Now later, because of the Wallerian degeneration, maybe people have shown Wallerian degeneration in the Vegas now in patient of Achalasia cardia. They have even showed Lewy bodies in the brainstem, which occurs in degenerative diseases of the nervous system, for example, Parkinson's disease. The cholinergic system also degenerate, and that leads to type 1 achalasia. So it is a continuum, but a continuum need not be true for every patient. It is like in some patient, you can get for the first time, they develop symptom and you find he has type 1 achalasia, but we don't know how long did he have asymptomatic disease, but I believe it is a continuum largely.
Thank you, Professor Ghoshal. I have a question. How the COVID-19 pandemic changed your practice in GI lab?
Yeah, actually, it is again a very good and timely question. We did an Indian survey, and in that survey, we found during the initial surge of COVID-19 in India, endoscopic practice was reduced to 10%. So, whatever endoscopy was being done in the country, only 10% of the elective endoscopies were being done. We practically shut down our motility lab for about 2 to 3 months. Now, what we are doing is we have started our work again. Only thing is our practice is all patient and his relative has to have a COVID-19 RT-PCR before they undergo a manometry test, and obviously all these precautions like PPE kit and 95 mask, they are required. So COVID-19 really changed our endoscopy practice, our motility practice, but it is gradually regaining now. We are relying a lot on telemedicine for outpatient clinic, and in fact we develop system in our institute to give a teleprescription, teleconsultation,
Thank you, Professor Ghoshal. I would like now to introduce Professor Daniel Sifrim. I'm really pleasure to introduce Daniel. He is a full professor for Engage Institute of Neurogastroenterology and Motility from Queen Mary University of London. He is one of the most important investigators of GERD and esophageal motility
Can you hear me?
disorder. Yes, Professor. We are introduced Daniel now. Thank you for your response, your answer. Sorry. Daniel, he will speak about the impedance-pH monitoring and its utility of esophageal disorders diagnosis. I encourage the participants to send questions to Daniel at the end of his speech. Thank you, Daniel, so much for your participation here. We cannot hear you, Daniel. Please open your...
Can you hear me now?
Yes. Thank
Yeah.
you. Yes.
Okay.
I will share the screen. Can you see my screen? Hello?
Not yet. Yeah.
I'm trying to share my screen, but I don't get it.
Probably, Fernando, are you here? Can you help Professor Daniel?
Okay, just 1 second, please. I will do it again. Share screen.
Please click in share screen.
Yep, I will do it. 1 second, please.
No problem.
Now I am showing my screen. Can you see it?
No, we don't see.
Okay. When I go to share, I cannot get it shared, so I will cancel again. And I go down to share screen, and then it's asking me.
Probably it's open for me.
For whom is open?
Yes.
And now, share.
Oh, yes. Daniel Sifrim is here.
Can you see the screen now?
Yes.
Yes.
Okay. Thank you.
All right.
Okay.
So, can I start?
Yes, please. Perfect.
Okay, I will repeat my introduction. I would like to thank the organizers for inviting me to this meeting. I will discuss today with you the use of impedance-pH monitoring and its utility in reflux disease and also in other problems like belching or rumination. So this is a video that shows how impedance works. This is a catheter that contains a pair of impedance electrodes, and you can see that the impedance drops when the bolus is passing through. You can see it again. It's a very interesting video because the subject swallows, and what happens at the very beginning is a rise in impedance and then a drop. And the rise has to do with entrance of air, and a drop with passage of the liquid bolus that is involving the two impedance electrodes. I show this for the last time. Okay. So if you imagine the situation where you have, instead of only two electrodes, you have multiple electrodes and the bolus is passing, what you see in the impedance is a sequence of drops and recovery, drops and recovery, drops and recovery, and this is moving in a up oral direction. Here is the mouth, here is the stomach, and the liquid is moving in that way, and you can see the movement of the liquid as a impedance drop and recovery. Now, if you are in an opposite situation where the liquid is moving from the stomach upwards, like in this situation, in that direction, so what you see is a drop in impedance, but in this case, moving from below in the stomach up to the mouth, and then recovery. So this is what impedance shows during a swallow of liquid, and this is what impedance shows during a reflux of liquid. Now, if we combine the impedance measurement with a pH measurement, and we see a reflux episode of liquid and a little bit of gas because of this spike, and there is a pH drop that crosses the threshold of 4, we are talking about an impedance reflux episode that happens to be acid. In contrast, if you have again a liquid reflux episode, but in this case the pH does not cross the threshold of 4, we are talking about a weakly acidic reflux. And if there is no pH drop at all, we are talking about alkaline reflux or weakly alkaline reflux. The combination of these two types makes what we call now non-acid reflux. Now, impedance has some advantages compared to pH-metry. In first place, it distinguishes between acid, weakly acidic, and non-acid reflux episodes. That helps to correlate non-acid reflux episodes with symptoms, which improves the possibility to make diagnosis of reflux symptom association. As I will show you later, impedance is able to assess movement of gas in both directions. And now we are using impedance to measure two novel parameters. One is the mean nocturnal baseline impedance, and the other is the post-reflux swallow-induced peristaltic wave, which are parameters that can help to better phenotype the patients based on reflux monitoring. And finally, impedance can be used both on or off PPIs, whereas pH-metry, either catheter-based or wireless, can only be used off PPIs. Let's have a look at a couple of examples of the usefulness of impedance. This is a pH recording. You can see this is 0, this is 9, and the line is pH 4. In this case, there are drops in pH below 4 that can be considered by pH-metry acid reflux episodes. However, if we add the concordant impedance tracing, you can see that these pH drops are associated to very peculiar patterns of impedance changes, which are not swallows. They include gas because there is a rise in impedance, multiple increases of impedance in the 3 times. So if we do a pH-metry alone and we don't know this, we will consider these drops in pH as part of the esophageal acid exposure. But what is this? When we expand one of these episodes, we see that there is a continuous drinking of liquid containing gas. In this case, that is a fizzy drink, is Coca-Cola. So in fact, the patient was drinking Coca-Cola, and that provoked these pH drops. I am giving this as an extreme example, but the practical use is that when we are performing a test, we need to look at the meal periods and try to make sure that the meal periods that are marked in the recording, that they correspond with the timing of the meals and drinking and swallowing, because many times the patient does not push the event marker properly, and many times part of the acid exposure is due to wrongly establish the limits of the meal period. So this is the first step in any impedance pH-metry analysis. The second issue concerning detection of reflux episodes is the possibility of detecting non-acid reflux. Impedance detects non-acid reflux, and in patients that are refractory to PPI treatment, this can be a cause of refractoriness. Patients are symptomatic in spite of a high dose of PPIs, and they are symptomatic to non-acid reflux events. Sometimes their symptoms are not related to any reflux. Now, what is a non-acid reflux episode? This is a typical impedance tracing. These are the drops with swallows, as I mentioned earlier. This is a pH recording in the esophagus. This is a pH recording in the stomach. And you can see that there is a pattern of reflux in the impedance recording without a change in pH. This is a typical non-acid reflux episode. Is it relevant, non-acid reflux? Well, it is not very relevant for mucosal damage. You will not have esophagitis or Barrett provoked by non-acid reflux. But it is relevant for symptom perception in patients with refractory disease. It is relevant in respiratory disorders with bronchial aspiration of non-acidic contents. And it is relevant in hypersensitivity to non-acid reflux. If you have 100 patients with reflux symptoms, you will see that 35 of those will have erosive disease if you perform an endoscopy, and you have 65 that will not have esophagitis or Barrett. Within this group of non-erosive reflux disease, there is a group that has hypersensitivity to non-acid reflux episodes. This cannot be detected by pH metry, cannot be detected by catheter-based or wireless pH metry. Of course, you can say, well, but this is a small group. Well, if you have millions of people with reflux symptoms, 30% of refractory patients, out of this 30%, 15% might be sensitive to non-acid reflux. That is not a negligible amount of subjects. The other important area where non-acid reflux is very important is in pediatrics, and particularly in neonates. The diagnosis of some respiratory disorders in neonates suspected to be secondary to aspiration of gastric contents or reflux can be made by impedance and not by pH metry, because most of these regurgitations are non-acidic because the stomach in these infants is full of milk. And there is an enormous amount of episodes of retrograde flow of non-acidic contents that can end into the lungs and provoke severe respiratory disorders. It is very well known, and pediatricians are using impedance to detect non-acidic reflux. So this is an important use of impedance technology. Now, I mentioned that there are patients in which you don't have a conclusive diagnosis of reflux disease based on endoscopy and pH metry. For example, they have an acid exposure of 5%, or they have around 50 reflux episodes, and the endoscopy shows an esophagitis grade A, and the symptoms are not particularly typical. So you want to know if the mucosa of the esophagus is healthy, is very healthy, or it is somehow touched by reflux. And impedance can give us a hint on the status of the esophageal mucosa. If you have the impedance catheter with the electrodes in the esophagus and there is a swallow or there is liquid, the impedance will reflect the ionic composition of that liquid, and if it is a swallow or if it is a reflux site. In contrast, when the esophagus is empty and there is no liquid, no swallow or no reflux, the impedance electrodes are touching the esophageal wall. And the esophageal wall has its own electrical conductivity is increased, the impedance is reduced. In other words, when the mucosa is leaky and there is a lot of ions moving around, the impedance is low. When we look at the tracing, an impedance tracing, at a period in which there are no swallows and there is no reflux, what we are looking is at this situation. The situation where the electrodes are in contact with the mucosa. In a normal subject, the mucosa has a high impedance, around 3000. In a patient with esophagitis, the mucosa is leaky and the impedance is lower, below 1500. In the middle, the patients with non-erosive reflux disease have a lower baseline impedance, but not spectacularly lower. So in some patients, we can think that the baseline impedance is low and that the patient might have non-erosive reflux disease. This is a study from Germany that showed that in patients with erosive disease and non-erosive reflux disease, the baseline impedance is below 2000, but you can see that there is a pretty good overlap, where a patient with functional heartburn have a baseline impedance in general much higher, similar to healthy subjects. So to put it in a simple example, if I have a patient with symptoms, they do not respond to PPI, endoscopy is negative, and the acid exposure is 4.5. And I want to know if the patient has functional heartburn or NERD. Having a baseline impedance below 2000 is moving the balance more to the NERD side than to the functional heartburn. And this is measured during the night because this is the period where there are less swallows and less reflux. We make a measurement of the night recording of the baseline impedance, and that is why we call it mean nocturnal baseline impedance. There is another parameter which is relatively new, and I find it very interesting. This is a reflux episode detected by impedance, and this is a pH, and the pH goes down. So this is an acid reflux episode. Notice that a few seconds later, after the reflux episode, there is an impedance drop that moves all the way down and coincides with an increase in pH. The only way that this can happen is whether this swallow brought some bicarbonate with saliva to neutralize the acidified mucosa. Now this swallow here that brought saliva is a reflex induced by this reflux. In healthy subjects, the majority of reflux episodes are followed by a reflexed swallow, 15 seconds, 20 seconds after the end of the reflux. It takes some time to stimulate the salivary glands to produce a little bit more of saliva that provokes the swallowing reflex, and that saliva brings bicarbonate to neutralize the acidified mucosa. This reflex is called post-reflux swallow-induced peristaltic wave. And in healthy subjects, this is pretty common. More than 60–70% of the physiological reflux events are followed by this swallow within the first 15–20 seconds. In contrast, in patients with reflux disease, this reflex doesn't work very well. In many patients with esophagitis, there are only 20–30% of reflux episodes that are followed by this swallow. In NERD, it's around 50%, and the difference is not that large. But when they put together the MNBI and the PSPW as parameters to help to make the diagnosis in a subject which has a negative pH metric, the acid exposure is normal, the reflux symptom association is negative, the endoscopy is negative, and they want to know if this patient is really symptomatic due to reflux or not. When they apply the PSPW and the MNBI, they find that the sensitivity and specificity is very good. Now let's move to another topic. Every time that we swallow food or water or whatever, and we swallow some air. Why? Because in our pharynx there is a dead space that is filled with air. And every time that we do a swallow movement, that air comes into the esophagus, into the stomach. This is a typical swallow, and you can see the bubble of air there. Now, we can see with impedance that when we swallow, there is air because the impedance rises. This is a meal period, another meal period. You can see that during the meals, some patients have a lot of air swallowing. This is what we call aerophagia, in Greek, swallowing air. Now, this is important because these patients might have, after the meals, reflux episodes associated to belching, and that belching might be increased because of the air swallowing during the meals. This belching related reflux is unlikely to respond to PPIs. This is the same period amplified, and you can see how many spikes we have during the meal. And if you expand even more, you can see that each of these spikes is air moving downwards. So in our group, we identify a group of patients with refractory symptoms to PPI treatment that have exactly this. Aerophagia during the meals, increased number of liquid and gas reflux postprandial, non-responder to PPIs. Detecting aerophagia with impedance is very useful because this has a relatively typical treatment. Now let's talk about belching. This video is not very easy to see, but you can see that there is a catheter inside, and the catheter is surrounded by a relatively dark environment. If I run the video, you will see that at a certain moment it becomes white. Now, you see that the environment becomes white. That white is air, even more white. This is air surrounding the catheter. And now there is a swallow or a movement that is emptying the air. All right, so let's see it again. I will stop it when I see the belch. Now, this is expressed here. A rise in impedance induced by air. And then there are two spikes. And then there is a peristaltic sequence that is clearing the air. You will see it now. The tail of the bolus of air is moving, like Dr. Ghoshal explained you earlier today, is a contraction here eliminating the air. And this is what we see here. This is an impedance volume clearance of liquid and air. So impedance can help us to evaluate movement of air. And there are different possibilities. This, as I said, is a liquid moving down. And you can see the drop in impedance moving down. In contrast, this is air moving down. The subject is swallowing air. This is what I showed you earlier as aerophagia. However, this is another situation where the air is moving up. So this is air coming from the stomach, moving upwards. And finally, there is the most interesting of the models is air that is moving in and out within the esophagus. This air never reached the stomach. So this is a liquid swallow, this is aerophagia, this is a gastric belch, a typical belch coming from the stomach, and this is a supragastric belch. It's air that is coming into the esophagus and it is eliminated out of the esophagus. Now let's have a look at this situation. This is a subject in which the pH metry shows many short-lasting spikes of pH drops. Many. A significant amount. Maybe 30, 40, 60 spikes of pH drop. What is this? Too many short acid reflux episodes. Even perhaps the total acid exposure is normal. Well, these are all spikes in the impedance tracing. Spikes in the impedance tracing. And most interestingly, the patient marks with the event marker many symptoms. These are symptomatic episodes. Each of these marks is one symptom. So, if you see many acidic reflux episodes, many spikes in the impedance, and many symptoms, there is something strange. These are not typical reflux episodes. These are supragastric belches associated with acid reflux. Each of these is a supragastric belch. Supragastric belching is a behavioral disorder that happens in general in young patients and is either expressed as a non-stop belching or as a increase in acid reflux that the patient do not realize that is due to his own belching. Very important to diagnose with impedance because the treatment of supragastric belching should be done not with PPIs, not with anti-reflux surgery, but with cognitive behavioral therapy and or addition of baclofen in low doses. This diagnosis cannot be made by pH metry. This is another situation. Again, this is the pH metry. Interestingly, there is a region here that is full of symptoms and not many pH drops. Another region there. So if I look at the impedance, this region happened immediately after a meal. So there is a meal here, and the patient has a lot of symptoms and many reflux episodes detected by impedance. All these are non-acidic retrograde flows of liquid. Most of them are recognized by the patient as regurgitations. This situation is until recently was considered a failure of PPI treatment in young persons that persist to have postprandial regurgitations. And we have recently analyzed a large set of these patients with postprandial persistent regurgitation in spite of PPI treatment. And we found this pattern of a significant number of non-acidic symptomatic reflux episodes, and this is rumination syndrome. Rumination syndrome can be very clear by the anamnesis. The patient is vomiting without effort immediately after the meals, or, and this is the most critical problem, can be hidden within the spectrum of reflux disease not responding to PPIs. We are finding more and more of these cases of hidden rumination in refractory reflux in young, particularly ladies, that we diagnose afterwards as a ruminator, and they respond pretty well to cognitive behavioral therapy with diaphragmatic breathing. Finally, I would like to share with you what we think at the moment. This was published a month ago. What are the best indications for impedance-pH monitoring? This was a comparison versus wireless pH monitoring, or Bravo. The first, as I said, is in patients with refractory, typical, or atypical symptoms despite PPI therapy, where there wasn't evidence of reflux disease before, and now we want to know why the patient is not responding to PPIs. So, refractory patients not responding to PPIs with previously documented reflux disease, they should be studied on PPIs with impedance-pH method. Second indication, patients with respiratory symptoms or a respiratory disease that is potentially triggered by reflux. For example, cough, or a respiratory disease that is prone to deterioration from reflux-related microaspiration. This is very typical in pulmonary fibrosis, cystic fibrosis, and after lung transplantation. In these cases, the best technique is impedance-pH metry rather than pH metry, because non-acid reflux is very common aspirated. As I said, in patients with repetitive belching, with or without concurrent typical GERD symptoms, and this is to identify aerophagia plus postprandial gastric belching, treatment of which is reducing the aerophagia with diet and potentially baclofen, from supragastric belching, which is a behavioral disorder that needs to be treated with cognitive behavioral therapy. And finally, the new indication is in patients with postprandial regurgitation in spite of PPI treatment. This patient might have rumination syndrome. So I discussed today with you the principles of impedance, the best relationship between impedance and reflux disease in terms of relevance of non-acid reflux, relevance of mucosal integrity measured with MNBI, and relevance of mucosal clearance as a measured with impedance with PSPW, the relevance of impedance in the understanding of belching and aerophagia, which is a universe that has been completely ignored or impossible to measure with pH metry or with Bravo, or even with mucosal impedance, in which you cannot see reflux of air, of course. And finally, the possibility to diagnose rumination. Thank you very much, and I would like to share with you a very beautiful picture that is always in my heart. Thank you very much.
Marcellus, no sound.
Unmute, Marcellus.
Yes, I'm.
Okay.
Thank you very much for your fantastic presentation. I'm waiting the question for the participants. One question is, what is your opinion about the duration of the pH monitoring? 24 hours is the best time, or we need more time to know what is happening in the esophageal disorders?
I must say that the ideal scenario will be more time. More time. And more time you can have with wireless pH metry. So I think that in patients where the symptoms are much more intermittent, not every day, and the symptoms are very typical, heartburn or chest pain. I will not be against the use of wireless pH metry for 72 hours or even 96 hours. But in patients where the symptoms are more atypical, are more frequent, are related to a little bit of belching or respiratory disorders, I think that a good 24 hours impedance pH metry will do the job. The two techniques are not competing with each other theoretically. One has an indication and the other has other indications.
Perfect. I have a question. In your opinion, how the artificial intelligence could be used for interpretation of pH impedance studies?
Can you repeat it? I missed for
yes,
2
sorry.
words.
In your opinion, how the artificial intelligence could be used for interpretation of pH impedance studies?
I think it is the present. It's no longer the future. I am involved in 2 projects. One on the measurements of impedance baseline and with artificial intelligence, and another for detection of supragastric belching with artificial intelligence, which is time-consuming and difficult. And they both are doing very well. They are now, yesterday, submitted to DDW abstracts. I think that this is almost the present. 1 or 2 more years, and the artificial intelligence will be doing the best job in analysis of. You know, the problem with impedance pH metry is that it is time consuming to do a good analysis. A rough analysis, everybody can do it. You push a button and you get a report. But that rough analysis doesn't give you what we expect from impedance, the difficult cases, the problems. And for that, it takes a lot of time. How much? 1 hour to analyze a tracing. Well, people does not have 1 hour every day to look at this. So artificial intelligence will facilitate that. I'm convinced.
Miguel, Carla, Professor Ricardo, do you have a question for Daniel?
It's Professor.
Sorry.
Go ahead,
Just
Professor.
a brief comment about supragastric belching. Usually it's a benign condition, but it may cause of damage to the social life or professional life of the patients. One of our patients, when they first came to the clinics, she was about to lose her job in bank branch. She was threatened by her manager of firing because the loud noises she produced at her workplace. So it's sometimes it's important to recognize and try to correct by behavior therapy, as you said, Daniel.
I agree on that, and I think that these severe cases are a drama for the patients. My new message today is that in parallel with the severe cases where the belching is the problem, there is hidden supragastric belching in patients with reflux disease. You cannot imagine how many patients with reflux disease have reflux and symptoms of reflux, heartburn, associated to a supragastric belch. At this moment, we believe that 30–40% of patients with reflux disease might be having this problem. That was ignored until now. So there are like 2 dimensions with supragastric belching. One is the case that you mentioned, and I think that this is dramatic and we need to recognize and help. But the other is the hidden problem that I think that is very, very common.
I quite agree, yes.
Thank you very much, Daniel. Miguel, do you have a question or go?
No, go on. Go on. Let's go on.
Now you have 3 cases from the high resolution manometry and pH impedance studies. The first case will be presented by Professor Ricardo Brandt, and probably with Gabriela Bueno, I think so.
Yes, I would like to take the liberty to introduce Gabriela Bueno. She's a medical resident in clinical gastroenterology at the Hospital das Clínicas de Ribeirão Preto, and she will present the case. Please, Gabriela.
Good morning.
Sorry, I want to introduce Professor Ricardo Brandt. Professor Ricardo is one of our mentors in our group in Fortaleza. He is full professor of gastroenterology in Faculdade de Medicina de Ribeirão Preto. It's a really a great pleasure to be you here, Professor. Go. Now you can go, Gabriela. Thank you very much for you.
Grateful for your kind words, Marcelo.
So good morning, everyone. First, I would like to thank Professor Ricardo for the opportunity. And thank you, Professor Sifrim and Professor Ghoshal for the brilliant presentation and the lecture. It's an honor. So now I'm going to share my screen. And you tell me if you can see the presentation.
Yeah, you can see.
Okay, can you hear me okay?
Yes.
Okay, so just like Marcelo said, my name is Gabriela Bueno, and I am a gastroenterology medical resident at Hospital das Clínicas of the School of Medicine of São Paulo University. And today I'm going to present a case of provocative impedance high-resolution manometry. So it's from a 46-year-old woman with an unremarkable medical history. She reported regurgitations without hatching or gagging over the preceding 6 months. The regurgitations typically began within 15 minutes of eating and would last for about 1.5 hours after nearly every meal. The episodes of regurgitation first included regurgitation of recognizable food material, but the regurgitations tasted more acidic as the episode progressed. She did not notice foods that increased regurgitation frequency, but in a few occasions she experienced regurgitation of recent ingested pills. She reported heartburn and epigastric pain and a 9-kilogram weight loss in recent months. She repeatedly denied dysphagia, purposefully restricted food intake, or binging and purging behaviors. Her physical examination was unremarkable and upper GI endoscopy was normal. So here we're going to start with the first high-resolution manometry frame. So this was a single swallows in the sitting position. And first we can see the low resting pressure on the esophageal gastric junction, but with an adequate relaxation after the wet swallows. Now, looking at the esophageal body response, we can say that the peristalsis is almost absent. with a really low peristaltic amplitude. And so the DCI in the medium of 10 swallows was 28 millimeters of mercury per centimeter per second, which is really below the normal value. And the IRP in the medium of 20 swallows was 9.3, which is within the normal value, but in the lower range. In sequence, in the next frame, this is the multiple rapid swallows test in the sitting position as well. And we can now see here that there is a peristalsis with high peristaltic amplitude following the multiple swallows test. We can also see some stomach contractions and the presence of gas in the esophagus. On this next frame, we can observe spontaneous, non-externally driven upper GI motor activity, which was recorded nearly 5 minutes after test meal completion. And now we can see this typical rumination syndrome manometric pattern, which shows a gastric strain, the common cavity phenomenon, and in the impedance, we can observe retrograde esophageal fluid flow and the upper esophageal sphincter relaxation. So here we can see an overlay of the manometry and the impedance image. Again, spontaneous and non-externally driven motor activity. So we can see the retrograde fluid flow concomitant with the upper esophagus sphincter relaxation and the gastric contractions. In this frame, we can observe that the episodes were recurring. So this was nearly 10 minutes after test meal completion. And on this frame, we just wanted to later discuss about the presence of a stomach contraction concomitant with the presence of gas in the esophagus, preceding the event of the rumination. And here is the video of the 3D model of the esophageal manometry showing the gastric strain and esophageal contraction. So now we're going to talk a little bit about the case outcome. So this patient was submitted to the following treatments. She was put in some behavioral therapy via diaphragmatic breathing, and we observed poor adherence to the treatment, leading to poor results. We tried as well the baclofen 10 milligrams 3 times daily, which we observed no clinical improvement, the persistent ruminating symptoms, and severe adverse effects such as drowsiness and dizziness. The patient was kept on proton pump inhibitors with the improvement of pyrosis. So now we're going to bring some questions to later discussion. The first one is there an association between the hypocontractility in the esophageal body, as we can see on this picture, and the rumination syndrome that the patient presented? Just to remember the audience that the DCI was really below the normal value. The second question for a discussion is the peristaltic contractions following the multiple rapid swallows were more vigorous in those following the single swallows, and if this could indicate a positive response to prokinetics in the present case. So here I brought a discussion for the variants of the rumination syndrome suggested in the Kessing et al. So the primary rumination is the abdominal pressure increase, resulting in the retrograde flow of gastric content, which is the most common mechanism of rumination syndrome. The secondary rumination, we can see the increase in the abdominal pressure that occurred after an onset of a reflux event. And the third one is the supragastric belch-associated rumination, which we can see that the abdominal pressure the increase occurred during the expulsion of air and preceded the retrograde flow of gastric contact. So the next question is, what variant of rumination syndrome are we dealing with in this case, in the present case? And the last one is, what is the next step for the treatment of this patient? And that my presentation ends here, and I would like to give the word to Professor Ricardo if he wants to discuss a little bit.
Thank you, Gabriela, for the case. I would like to know if Daniel could
Yes.
comment this case.
I will try to answer the questions first. The first question concerning the hypomotility in the esophageal body, in my mind, can be due to two possible reasons. One is that the patient has a universal hypomotility, not only in the esophagus, but also in the stomach, with delayed gastric emptying and perhaps even in the intestine. So one thing that I suggest to do is to measure gastric emptying times and see if she has a severe gastroparesis together with esophageal body hypomotility. Because if this is the case, this is more than an idiopathic rumination, but it can be a patient with a pan-GI hypomotility. The other possibility is, and this is related to the second question, is that I couldn't see the type of air movement before the rumination event, but the way you present it suggests me that it might be supragastric belching preceding the rumination. And if this is the case, the hypomotility in the esophageal body is very commonly observed in patients with supragastric belching. The reason, I don't know. My hypothesis is that the esophagus is distended chronically by air, and it works like the right ventricle in the heart, which is distended, and has a hypomotility. I don't think that the muscle is damaged, because post-MRS, the after contraction is good. So I think that this is more a functional hypomotility, and it can be secondary to continuous presence of air. So if this is the case and the rumination is supragastric belching related, the target is the supragastric belching. And the CBT is different than only rumination with diaphragmatic breathing. It's a little bit more complicated. So I think that the two questions need to be solved: whether there is a pan hypomotility, and two, whether this is supragastric belching related, and that needs to be treated a little bit different with a mouth opening, tongue behind the teeth, a part of the abdominal breathing. Final comment is the prognostic value of the after contraction present for use of prokinetics. We have studied this and unfortunately never managed to complete it and publish it, but we had preliminary data showing a response to azithromycin, who is a macrolide antibiotic that has a similar effect to erythromycin, both on gastric emptying and esophageal contractions. So the patients that had what we call now good peristaltic reserve, an adequate contraction post-MRS, were those that responded better to azithromycin. So these are the three questions that you propose, and I discussed them all. I suggest to try a macrolide antibiotic, the one that you have available. I suggest to look at supragastric belching before the rumination, and if it is present, do the proper CBT relative to that. And the worst case scenario is that she has one of these pan-hypomotilities. And if you ask me how to treat it, my answer is, I don't know.
Okay, thank you.
Yes, Professor Ricardo, do you want to comment?
Unmute, Ricardo, you need to unmute.
Sorry. Thank you very much, Daniel. I was unable to answer the questions Gabriel had put for me. So I'm very grateful to you for doing so. Thanks.
Let's go to another case. The second case will be presented by Dr. Carla Granja. Dr. Carla is a Master of Surgery at the University of São Paulo and member of the Brazilian Society of Esophageal Motility and Neurogastroenterology. Thank you, Carla, for your participation here.
Thank you very much for the invitation. I'd like to congratulate the professors for the brilliant exposures before, and let's see the case. Can you see the exposure?
Yes, Carla.
Yes. Yes.
Thank you. Thank you. The case in June of 2080, a 56-year-old woman was referred by a surgeon to our digestive motility service for a preoperative evaluation of bariatric surgery. At that time, the patient had a body mass index of 42.9. As a comorbidity, only arterial hypertension, and at the standard questionnaire of our digestive motility service, she reported heartburn related to eating sweets and fats, and denied regurgitation, chest pain, dysphagia, cough, or dyspnea. She had the result of endoscopy that showed grade Los Angeles classification grade A esophagitis, and without hiatal hernia and gastric polyps. And she was, in that time, not using PPI for a long time. This is the result of the high-resolution manometry that was normal by the Chicago classification. And here I can call your attention for some metrics. She had a type 1 morphology of the esophageal gastric junction with normal resting pressure of the lower esophageal sphincter by 3 metrics, and esophageal barrier with excellent contractile vigor, DCI above 1000. This is the image of the esophagogastric junction at rest. And this is the image of the dynamics of swelling of this patient. We did a pH metry tool that shows that this patient has exposure at total time about 6, and the Mr. 25.3. And this is the image of the pH metry. Here we have two questions. Preoperative findings are decisive in helping to choose the best technique in these patients. What's the choice would we make for this patient? This is a work presented at SAGE 2019, shows a chart that tries to organize the reasoning of these cases. And here, this work suggests that we need to ask the patient if she wants to do, or the patient wants to do a sleeve gastrectomy, and if has symptoms of reflux, if the patients with mild or infrequent symptoms with PPI dependency or a normal esophagogastric endoscopy or esophagogram, the sleeve gastrectomy was deemed permissible. But if we have many symptoms, if the patient has pH testing or high-resolution manometry altered, the patient must be recommended to Uday gastric bypass. But this patient did sleeve gastrectomy, delayed it, and then returned to last month to our digestive motility service, showing great weight loss, but complaining about worsening of the symptoms of the GERD. She reported worsening of heartburn, regurgitation, clearing throat, and sometimes she has trouble swallowing solid and dry food. And she mentions that there has been a worsening of quality of life despite weight loss, and says that the surgeon suggested that maybe she had to do a reoperation to a conversion to a bypass. I apologize by the quality of this endoscopy, but this is the endoscopy of after the surgery, and she has in the description of the report a grade B esophagitis and a hiatal hernia. This is the results of the high-resolution manometry, and now, 2 years late, we can see a decrease of the lower esophageal sphincter pressure, a type 3 morphology of the AGJ, a decrease of the DCI, and afterwards we have 40 swells that are ineffective. This is the image of the AGJ after surgery, and this is the image of the esophageal barrier of this patient last month. We did multiple rapid swallows, 3 samples, and she has an increase of the DCI numbers, what shows that she has a contractile reserve preserved. Something very interesting is that when we do provocative tests with multiple rapid swallows, we usually do it to testing the DCI, the reserve contractile. But when we do this, we are trying to simulate a situation of a real life, the way that the patient do the swallows. And when we do this, in this kind of patients, we have sometimes an intragastric pressure elevated, that we can see in this this sample of the multiple rapid swabs. I think it's better when you do this with the patient in a upright position, and sometimes if you can do it with not just liquid but solid, it's very, very interesting, very interesting. Why is easier? Why is hiatal hernia occur easier? It's easier to happen after sleeve gastrectomy. The stomach is transformed into a tube of high pressure and low complacency, and the ease angle is undone. This is the GEPH impedance monitoring of this patient, and we have worsening of the demister and the fraction total time, exposure total time, acid exposure total time. And we have many symptoms that are related with the acid reflux. Besides, we have elevation of reflux that occur no acid reflux too, and we have here mean nocturnal basal impedance below 2000. This is the image of the impedance monitor of this patient. Here, acid and non-acid reflux. And in this image, we have a long duration drop of the line of the pH, and what we call the reflux situations, that the patient trying to clearance the esophagus with some regurgitation, some swells. The other questions I want to do is, what's the frequent manometric finds after sleeve gastrectomy? There are applicability to provocative tests in these cases. And if there is a difference in performing pH metry and pH impedance in evaluation of gastroesophageal reflux post-sleeve gastrectomy. Thank you.
Thank you very much, Carla, for this case. I would like to ask Professor Ghoshal if he could discuss this case.
I think it was a very interesting patient, but the physiology that happened after the surgery is not entirely unexpected, because once, as you said, that stomach's capacity is reduced, then obviously the esophagus is affected. Not only that, during the surgery, there is a possibility of the damage to the nerve. Therefore, the relaxation of the fundus, which is mediated primarily by the vagus nerve, may also get impaired, and that may lead to reflux and some changes in the motility. So what is your thought about this, that could there be changes in the nerve supply to the fundus and therefore fundic relaxation, and the capacity of the stomach which got reduced, leading to increase in the intragastric pressure during multiple rapid swallow, and therefore that could have led to change in the esophageal manometry parameter following the surgery?
Thank you very much, Professor Ghoshal. Carla, do you want to discuss the comments of the Professor Ghoshal?
Yes. We have frequently seen these alterations in patients post-operative gastric sleeve gastrectomy, and the situation is that sometimes we see intragastric pressure elevated, and sometimes we not. Maybe 50% of these patients have intragastric pressure elevated. I think the provocative test is a good way to test these patients and intragastric pressure in these patients. And sometimes we observe the elevation of the acid exposure total time, but it's not so hard. And when we have the intragastric pressure associated with motility, ineffective swallows, we have pH metry and impedance-pH metry that are worse and with elevated numbers.
Thank you, Carla. Professor Daniel, do you want to discuss about this case? I know you have studies with the patients before the bariatric surgery, and it's very interesting the results about the esophagitis, the prevalence of esophagitis in this case.
Yes, I have two comments. The first is that this patient should have never had sleeve gastrectomy, having reflux disease preoperative. It is well known and published that patients with reflux symptoms and or endoscopy or pH metry positive will respond very badly to sleeve gastrectomy. So I disagree with the algorithm that was presented justifying the sleeve gastrectomy. This is not a patient for a sleeve gastrectomy. The second issue that I wanted to mention, which is not exactly related to this case, but I find fascinating, is that obese patients have hyposensitivity in the esophagus. They are like Barrett patients. They do not feel very much acid in the esophagus. So there are many patients that get bariatric surgery without being objectively studied for reflux disease, just based on a symptomatic questionnaire. They don't have heartburn, they don't have regurgitation, and they get a bariatric surgery, and thereafter there are the disasters coming. So one thing that I would like to stress is that every patient that goes to bariatric surgery should have an objective exclusion of pathological reflux preoperative. It's not enough, the absence of heartburn. And finally, concerning the intragastric pressure and the effect on the reflux, I am not surprised. The patients still have transient LES relaxations, with a increased intrafundus pressure will always be associated with acid reflux. So I think that the scenario is set to get not only acid reflux, but these are in general young patients that they have 20, 30, 40 years ahead, and the risk of Barrett cancer is there. So what are you going to do with this patient now? The question of transforming the surgery and stopping reflux is not a theoretical or hypothetical question. It's a danger to have a patient with such a amount of reflux for the next 30 years. So this patient needs to be reoperated, whatever you want to do, if a Roux-en-Y or a hernioplasty or whatever, to stop reflux.
Thank you, Daniel. Carla, do you want to discuss more?
No, I agree
case?
completely with Professor Daniel, and I think this is true. What we have to do with these patients need to be evaluated preoperatively and do a well evaluation, not by symptoms only. They need to do exams and we need to stop this reflux. So we have to do to give a solution to these patients. I agree, these patients didn't need to do don't have to do a sleeve gastrectomy. Sorry.
Thank you. Now you have the last case that will be presented by our chairman, Professor Miguel Nobre Souza. Professor Miguel is an associate professor from the Federal University of Ceará. Miguel, go ahead.
Thanks, Marcellus. I will present a very short case, a different one, and I think we can discuss some other topics till now undiscussed. Where is the... Just a minute. Try to share screen. Share screen. It's okay now?
Yes, yes, you need to find your presentation.
Yeah. Okay. Are you seeing the presentation?
Not yet.
Not yet.
So let's see. Share screen. Share screen.
You need to open your presentation first.
I just
Yeah.
open.
You shared the screen, but you did not open your presentation. So
Yeah,
please
so
share the screen and again, and then open presentation.
I will close it and open again. Just quit PowerPoint. I'm opening it again.
Fernando, you are here?
No, you are not. Now you have not shared your screen. Please first share your screen, then open the presentation.
Yes.
We could share your screen.
It's correct. It's correct. First, share screen, and then...
Yeah. Share the screen. And let's see. It is not here.
Change the option, the share screen. To
Yes, I have changed.
change to window janela do aplicativo. Change.
Please, Fernando.
Yes.
Help.
I am at janela do aplicativo. The problem is that it doesn't show. Let's try.
Yeah, yeah, you have shared your screen. Open the presentation.
The presentation is open, but you can't see, yeah?
No.
No, presentation you have not opened, it seems. It seems you have not opened the presentation.
Você abriu a tela do StreamYard para essa apresentação.
PowerPoint?
Não, para a apresentação do StreamYard.
Ok.
Para de compartilhar a tela.
Let's go there. Parei o compartilhamento.
Isso. Entra de novo no compartilhamento.
Eu já fiz isso. Só se eu sair.
E compartilha a tela inteira, não compartilha o aplicativo.
Tá. Share screen, tela inteira.
Isso.
Ok.
Tem 3 abas.
Ok. And now?
Aí sim, ok.
Thanks, Fernando.
It's okay now. Go ahead, Miguel.
Thanks, Fernando. Well, sorry for the delay. I will present an esophageal dysphagia patient associated with mild myopathy. It's a very simple case, a very rapid case. We have some relevant clinical facts. In February last year, she had GERD and was submitted to an anti-reflux surgery. Well, after the surgery, she had mild and short duration dysphagia. It was not a problem at all. In August last year, there was GERD recurrence, and she needed PPI continuously. This year, on 9 March, and she had a surgery for varicose veins. And 1 week later, she began 1 week of fever, 2 weeks of headache, muscle pain, and adynemia. Her serology was positive for COVID-19. Well, she stayed there till July this year, when we could have some investigations about her complaints. That at that time, July this year, was diminished proximal muscle strength that disturbed her for some household tasks, esophageal dysphagia, mainly for solids. That's why she came to us. She had no weight loss. Her body mass index was 25. She had some relevant clinical past conditions, a mild but stable multiple sclerosis needing no treatment, and carpal tunnel syndrome. She took an electroneuromiography in 2019. Well, the diagnosis was only a localized neuropathy due to carpal tunnel syndrome. And this year, in June, and the diagnosis was proximal myopathy and carpal tunnel syndrome. Her brain MRI this year had no new findings relative to previous ones. An upper gastrointestinal endoscopy, June this year, showed mild esophagitis, grade A, a 4 centimeter height of hernia, and no film duplication was seen. This high-resolution manometry was performed before film duplication in February 2019. Well, nothing special except for the type 3A gastroesophageal junction. And the esophageal body motility was pretty normal. This year, in July, high-resolution manometry, it was really different. We couldn't see esophageal contractions in the proximal esophagus. Well, the gastroesophageal junction was the same. Film duplication was completely absent. And just to make it some more quantitative, a kind of proximal CI, taking only the 4 centimeters of the proximal esophagus, resulted in 0 in this high-resolution manometry in all deglutitions. It was small in the previous one, ranging from 0 to almost 60. Well, this kind of, you can see here, also it's important to say, you may think there is a hypotensive UES sphincter here. In fact, there is not. During the same examination, you could see a pretty nice upper esophageal sphincter here. Probably this was due to some dislocation of the manometry catheter in this position. Let's review that swallowing function is very different from mouth to the distal esophagus. There is a skeletal muscle that is responsible for the initial phases of swallowing. And the mechanisms associated with dysphagia during these initial phases are a reduced pharyngeal contractility, a cricopharyngeal dysfunction, a reduced elevation of the larynx, and also proximal esophageal motility. The proximal esophagus typically going down to the aorta is mainly composed of skeletal muscles. That pattern is really different from a very intense manometry pattern during to another disease that that causes dysfunction to the lower third or lower 2/3 of the esophageal muscle. I'm talking about systemic sclerosis. Even in this situation, you can see pretty nice contraction in the few centimeters of the skeletal muscle esophagus. This type of contractions you couldn't see in our case. So that's it. Open for questions and comments. Okay. Okay. Marcellus?
Thank you for your case. I
Oh.
would like to know if Dr. Ghoshal could discuss this association between the COVID-19 and the distinction of esophageal motility. What is your opinion, Professor Ghoshal?
Only thing is, I'll ask a question. You said that the antibody to COVID-19 was positive, but did the patient also have an RT-PCR test?
PCR?
Yes.
No PCR, only serology. Serology and feverish and clinical setting.
Yeah, only thing is that since RT-PCR was not done, we don't know when did the patient actually get COVID-19. Because presence of antibody means there is a prior exposure, and the prior exposure might have led to COVID-19 or coronavirus associated disease, or it may be just an asymptomatic carriage. Now, but obviously it led to exposure, it led to infection. Now, about what are the gastrointestinal consequences of COVID-19? See, what happens is COVID-19, 10 to 20% patient can have GI symptom. And the GI symptom can be nausea, can be vomiting, can be abdominal pain, diarrhea, even constipation, and abdominal discomfort. 10 to 20% patient have. But usually these are short lasting. What happens is we hypothesized just recently, the paper came in PubMed that COVID-19 may lead to long-term gastrointestinal consequences and in the form of functional dyspepsia, in the form of irritable bowel syndrome, because this is like post-COVID-19 FGID. And we have compiled some evidences, and just today it came in the red journal in the red section. But as far as COVID-19 and motility disorders are concerned, there are hardly any data. There is hardly any data. In fact, I remember we described one patient. The patient has had varicella zoster, and following varicella zoster, patient developed Achalasia-like esophageal pathophysiology, along with severe gastroparesis. And after a few months, patient obviously recovered from varicella zoster, and the motility abnormality also markedly improved. And this case we published in Journal of Neurogastroenterology Motility. So what I'm saying is, can COVID-19 lead to neuropathy-like situation affecting esophagus or the GI tract like pseudo-obstruction? Nobody really knows. Just recently, we got a paper submitted to our journal, that is Indian Journal of Gastroenterology. This is a single case report of jackhammer esophagus associated with COVID-19. but this is just an association. Patient might be having jacoma esophagus before. COVID-19 is known to affect other muscles like heart muscles, cardiomyopathy. COVID-19 is known to affect brain. So therefore, there could be a remote possibility, but I'm not sure whether it is related to COVID-19 or not, because we do not have proof that the patient had COVID-19 or the disease due to SARS-CoV-2. It is just an antibody positivity, and we found in areas of India where the disease is very endemic, as high as 10 to 20% of healthy people develop antibody without experiencing symptom of COVID-19 ever. So this is what I thought. Yes, the patient has hypomotility, marked hypomotility involved in the esophagus, something like myopathic changes in the esophagus, along with the low ileus pressure, which actually suggests the muscle involvement at the esophageal level.
Do you want to discuss the comments of Professor Ghoshal?
Oh yes, for sure. We cannot say that COVID is the cause of this proximal esophageal kind of myopathy, if there is a myopathy. It's just an association. But we have 2 points that, well, turns it a little bit more possible for a real cause and effect association. One is that, well, there is no PCR, but there is an IgM serology positive. And also, there is a new onset peripheral neuropathy documented by electroneuromyography concomitant with dysphagia. Also, the patient had dysphagia. And at last, the patient is better. She has no more dysphagia. Unfortunately, she didn't agree to take another manometry, at least till now. That's it.
Yes, thank you. We have a question from Carlos Victor. I would like Daniel could answer the question. It is possible to use the magnetic ring in this type of the patient with regurgitation and GERD? What is your opinion, Daniel?
But this is not related to the case of Miguel, right?
No, that's not relevant. But you can discuss also the case.
Well, just first, I would like to say something about the case of Miguel. The fact that the UES was not affected, to me, makes it more difficult that the proximal skeletal muscle is involved. They are a very similar and anatomical, very close structures and a very similar neural regulation. So I must say that only the striated esophageal muscle without the UES affection, to me, is very difficult to understand. And I agree with Professor Ghoshal that maybe the problem is more a smooth muscle regulation involving the dysphagia rather than the hypomotility more proximal.
Okay.
Concerning the question of use of the links in patients with regurgitation, I think that the LINX is a very interesting device. It is used now in patients with refractory GERD with some success. The indication of LINX in patients with hiatus hernia is a problem. So if the patient has regurgitation in the context of a hiatus hernia, LINX is not very much recommended.
It's important to know if the regurgitation is not the rumination. No, Professor Daniel. It is a different condition that the rumination could be expressed as the regurgitation. It's very important because the treatment of regurgitation could not be using rings. It's a very important point, in my opinion.
I am not going to treat a ruminator with a LINX. No way.
Yes, but the diagnosis is not so simple.
Of course, of course, of course.
Miguel, could you now you can take the section.
Okay, just one more comment about Carla's case. I don't know if, in my case, probably weight loss might benefit and possibly control reflux, since the mechanisms of reflux in obese patients, the main mechanisms is an elevated and high intra-abdominal pressure, but just mild cases. Well,
Can I say something more about that? These patients have bile reflux together with acid, and 40 years of acidic bile reflux in a young person is very dangerous.
sure.
What I would like to
Very dangerous. Yeah, yeah. Yeah. Marcellus, can I say something about the Miguel
Sure.
case? This case is very interesting. It's a peristalsis, fragmented peristalsis by the Chicago classification, and we don't know what it means, fragmented peristalsis. And the question is exactly this. This is fragmented by a problem in the proximal or in the mid esophagus. So it's a challenge to help this patient. What you think to do to solve the dysphagia of this patient, or suggest?
Well, yeah, this case, it was really easy because dysphagia disappeared spontaneously. So the patient has no problem now. Okay.
Okay.
In cases of severe myopathy, like dermatomyositis or polymyositis, it's really difficult. You have to treat the baseline disease, and well, probably you'll get around treating GERD, not the motility problem of the esophagus, if the patient have GERD. So that's it.
Yeah, I have a comment here. You see, I agree with Professor Daniel that this is not a skeletal muscle disease. This is a smooth muscle disease. So skeletal muscle, in fact, in upper esophagus, you had beautiful contractility. And if somebody has skeletal muscle disease, you will have symptoms which would be different. It will be more of a transfer dysphagia rather than esophageal dysphagia. This patient probably had esophageal dysphagia. Also, if you look at the causes of skeletal muscle disease, this will manifest with many other associations. Like typically neurological patient have skeletal muscle disease. We know that myasthenia gravis can have skeletal muscle disease. There, if you keep on taking multiple swallows, as you see, the later swallows will be having more hypomotility than the earlier swallows, which is typical of myasthenia. So it is smooth muscle disease. Now, what we know is that if somebody has really severe GERD, GERD leads to esophagitis, and the esophagitis can impair muscle contractility. So if you give a good PPI, or rather if you give a good dose of PPI, improve esophagitis, sometime muscle contractility may increase. Now, second thing is that you have very limited option really to increase the function of the esophageal muscle. Now, we found, this is an anecdotal experience, we did not publish it, but there are literature, but scanty literature. If you give pyridostigmine, actually this patient improve. And pyridostigmine neurologists use quite a bit. And what happens is pyridostigmine one option. Yantac showed that other drugs such as mirtazapine, and even he showed there are some studies with tegaserod that these improve esophageal motility as well. So either by serotonergic mechanism or by cholinergic mechanism, you can improve motility. And obviously there will be other option like a patient has to eat in the sitting posture rather than standing posture, and all those lifestyle things will be useful. So what happens is you have very limited option to improve the esophageal smooth muscle function. So I would say pyridostigmine, other drugs that I mentioned, and then treating esophagitis if it is there with a good acid suppression.
Okay, thanks, Professor Ghoshal. Yes, anybody else to comment? So we're coming to our end. That's it. Well, once again, I would like to thank Professor Uday Ghoshal. I hope we can meet again in the near future, online or not online. Professor Daniel Sifrim, we miss you very much. Okay, and thanks again. Professor Ricardo Brandt, we also miss you very much. Carla, thank you very much for coming. Gabriela Bueno, thank you so much for coming. Marcelos, see you
later.
Monday, yeah, Monday. Monday. Okay?
Bye-bye to all of you.
So,
Bye-bye.
Bye-bye. Bye-bye. Thank you very much.
Bye-bye.
Bye-bye.
Bye-bye.